Good afternoon, welcome. I'll quickly introduce myself and then our speaker. My name is John Goldblum. I'm at the Cleveland Clinic and I'm president of USCAP this year. It's my honor to be able to introduce our Nathan Kaufman Timely Topic lecturer, Dr. Eric Glassy, who's sitting to my right. I'll give you a little bit of background. Dr. Glassy received his medical degree from the University of California in San Francisco. Did his pathology residency and a hematopathology fellowship at Harbor UCLA Medical Center. Board certified in both anatomic and clinical pathology, obviously with a special interest in hematopathology, but also, importantly for this lecture, interest in and expertise in information technology and digital pathology. He's had many important positions, has served as laboratory director for a number of Southern California hospitals. He's very active in the College of American Pathologists. He's served on innumerable leadership committees and positions, including the Hematology Resource Committee, Publications Committee, Council on Education, Council on Scientific Affairs, and actually many, many others that are probably too many to mention here. He was honored by the CAP with a number of awards: the Pathologist Distinguished Service Award, Pathologist Honor Award, and Excellence in Education Award. He's a well-known lecturer and has authored several publications in his fields of interest. He's edited and illustrated the CAP Color Atlas of Hematology, Color Atlas of Body Fluids, and the Color Atlas of Urinary Sediment. He's president-elect of the Digital Pathology Association and chairs the CAP Digital Pathology Committee, and was recently appointed as a trustee of the American Board of Pathology and is a governor for the CAP. So it's, without further ado, I would like to introduce our speaker, Dr. Eric Glassy. Please welcome him.
Thank you. John, thank you.
Sure.
All right. Oh, gosh. You know, I'm just a community pathologist, so being at USCAP and presenting this lecture is quite an honor. And last night at John's presidential affair hosting all of the speakers, I had a chance to meet some of the greats in the field that I have their books, and it was wonderful to share a ride with Jan Silverman on the monorail and stuff, and see Sharon Weiss and many others, Dick Sarbo. So I'm very, very honored, and thank you, David, for bringing me here. A lot of famous folks have done this lecture, and I am absolutely one of the lesser lights here. And David had a particular reason for asking me to be here, and I think it showcases his talent. So I'm much appreciative of his expertise, which is in film. You know, besides just being a cytopathologist, he has an Academy Award nomination. Not too many pathologists can say that. Emmy nomination. He is knighted by the Italian government for his, I mean, it's just like incredible. So compared to that, who the heck is this guy up here, you know? Well, John listed some of my credentials. You know, I'm in a private practice group, affiliated pathologist medical group. We got 35 folks in that group, and we cover a number of various size hospitals and reference labs. I'm honored to be a trustee of the ABP and was recently appointed governor of the CAP. So I am very, very fortunate. And people try to build up a body of work, and this is my body of work, the things that are most important. But the one book that I really am most proud of is one written by an oncologist, David Chan. And my mom died many years ago of breast cancer, and sort of as an honor to her, I did the illustrations in that book. So a few conflicts. I am a consultant and part owner of Pathology Inc. I've done consultations for Aperio, Leica, and Precision Medical Network, and none of those products will be pushed today. So this is a keynote presentation, keynotes. So this is what we hope for, right? The speakers want this to happen, and this is often the reality of the situation. You know, it's the reaction of audiences on keynotes is divided into 25% of you are going to be rapt attention, listening to every word. 25% are going to have mild interest, and the other 50% are going to daydream. And they've done studies about people who have daydreamed, and it turns out that those that daydream Most of them are daydreaming about some sexual fantasy while you're daydreaming. So I'm very happy to bring so much pleasure to half the audience. All right. And you know which half you are, right? Okay. All right. Can we predict the future? You know, is that possible? Well, I had some Chinese food a couple of nights ago, and my wife got this cookie that said, "Today is the one day in all the days that are to come." It's the usual, like, I need to translate that a little bit. My cookie that I opened had this. So I hope that does not actually happen, because we've got a lot of technology up here. We'll see. So it's always good when you do these things to get some advice. So I asked 2 women for advice when I was doing this talk. The first one is my wife of 40 years, Chris, and she told me, "Eric, don't try to be witty, funny, or smart. Just be yourself." So, you know, it's wonderful to get encouragement. Okay. The second is this person, this lady, and so I asked, "Tell me about the future. Can you predict it?"
Predicting the future is a dangerous pursuit. For example, many scientists predicted that man would one day walk on the moon, but no one predicted that we would watch it on TV.
No one predicted we would watch the moon landing on TV. Most interesting.
I have more computing power than NASA had in 1969 when we launched the Apollo spacecraft on its trip to the moon. But I spend more time playing Angry Birds and launching birds into pigs.
Yeah, that's where the technology goes. So how do we predict the future? So I think we need to find a futurist, someone that can tell us about the future. So we got a bunch of choices. One could be Ray Kurzweil, you know, ask him. And he's the proponent of the singularity, when there's a crossover between machine intellect passing human intellect sometime in 1940 or so, 2040 or so, that's supposed to happen. Or Dr. Kaku, and we could ask him about predicting the future, and he's talked about many things that are supposed to change and improve in our lives, like mind over matter and rise of machines and planetary civilizations and such. But this is more my style. I think Woody Allen probably summed it up better. Time is nature's way of keeping everything from happening at once, or we're all interested in the future because that's where we're going to spend the rest of our lives. And that kind of captures a bit of this talk. Now, if you want to leave now, it doesn't get better than this. There's no real CME stuff in this talk, so I'll go ahead and head for the exit if you wish. So Woody gave a bit about, you know, he said many people are afraid of advanced civilizations landing on Earth and taking over because they were so advanced. And he said he's not worried about that. He was worried about civilizations that were 15 minutes ahead. You know, that's all they had to be to cause him to be afraid. And he said if you were 15 minutes ahead, you would be first in line at the movie or the bank, and you would be ahead in the checkout line. You could be the stock market guru with just 15-minute lead time. All right? And in a lab, if we had 15 minutes that we were ahead of everybody else, we could do stats running before they asked us. We could have specimen problems solved before they were called, ready to pick up the phone and respond to the clinician. We could be the first to make the correct diagnosis. So I'm going to be the short-range futurist. The things I'm going to talk about in the next 40 minutes or so are just things that are on the horizon or here and not too far out. I don't want to do things that are completely off base. So the promise here is to explore some of the near future trends and emerging technologies that will impact pathology. And the most important part is to have some fun when we do that. So I'm going to break it up into 3 broad trends. The first is paper, the second is Smarties, and the third are selfies. That's how I'm going to break up this talk. Let's talk about the first, the fall of paper. All right?
Peter, come take a look at this.
Mr. Daniels.
Mr. Daniels.
Look at this. What's this?
The numbers, they keep getting bigger and bigger.
Clicks are off the charts.
Yeah.
Yoshi, it's Walter. We're back.
Yes, sir! I need more trees. More, please. I'll get you more trees.
Hey, take a look at wood pulp.
Everything you got on wood pulp right now.
He really loves that thing.
That's where we're got to be careful there, right? So the oldest printed book, 256 AD, is displayed here, and supposedly the father of paper was Kai Lun about that time, and he invented paper. And books were often thought of as the domain of the rich, right? And we have some elegant edifices for those books, the Milan Public Library. And if you mapped out paper consumption in the United States, it took a dip in 2006, going on down, and it continues to drop. And if you map the purchase of tablets, it sort of coincides with the drop of paper and the rise in our access to electronic books. And in the terms of e versus paper books, Amazon in 2011, e-book sales surpassed printed books. If you go to libraries are full of books and computers now. The juxtaposition of technology and paper. There's the first bookless public library opened in San Antonio 2 years ago. And Amazon, to reverse things, appealed to bitextuals by opening up a series of brick and mortar stores. So we've come full circle, all right? And this is the very first app, right? So it's called the Reading Wheel, and the individual, the scientist here, has multiple books open, and they can quickly move from one book to another, much like we do on an iPad now, just a bit bigger. So I predict that books will become more interactive. We'll have whole side links, video and audio links, and the evolution of paper and books will become more electronic. So this is, I'm currently working on the second edition of the Heme Atlas, and we've got a lot of what I think are nice whole slide images incorporated into it. So for the different examples here, you have, you scan the QR code on the static image, and it launches and goes into the website, and now you have the image in context. You can move that around and see the case completely. We feel that's a much more interactive method of enjoying learning. Other magazines and journals have incorporated the same QR code technology. Archives did one last year, and then again more recently, in which the images are associated with QR codes, and when you scan those codes on your tablet, it takes you to the individual image. Instead of looking at the static one, you're looking at the whole slide, and I think it's a terrific way to see things in context. All right. That recent issue of Archives also had video incorporated, not just whole slide images. So that's where paper is going. A number of other journals have done the same thing. So textbooks, I predict, are going to help us learn, and the textbooks themselves will learn. They'll produce quizzes for us after every chapter. They'll highlight material we need to review. They'll summarize progress to teachers about how students are doing, and it'll be an enhanced learning experience. Another thing that'll happen is augmented reality will become more integrated into our lives. It's already being used in some surgery suites to orient and to talk about, or orient and to suggest particular surgical approaches. And on your table, you've got, or on the chairs, we've got some cards, and one side of the card has an app that, if we could switch over to the iPad, has an app that you can download on your iPhone or your iPad, and on the other side it has two drawings, and if there's one that's a heart, and you launch the app, and this is my view right now of kind of a darkened stage. But if you put it down onto the card, you now have a 3D representation of a beating heart, which you can manipulate. You can remove the vessels and watch the blood actually flow through the heart. And if you flip the card over, you've got 3D representation of a body, which you can, if you're teaching, you can remove the skin, lymphatics, nervous system, the muscular system. Okay, how's this? Just yell. Yeah, it's on. Yeah, that's okay. All right. So light it up. And it's a great way to interact and to teach kids anatomy. So something to play. And other books will have, we can switch back to the main presentation, please. Other books will have the same interactivity. All right, augmented reality. So to me, publications of the future will have a mix of traditional paper books that we all love with e-books, which will be interactive with video and apps. But what about pathology? What about our paper that we send out? So we've got path reports that have a diagnosis, images, headlines perhaps, and you could incorporate the QR technology onto these reports, and if you scan that code or the doctor scans the code, the clinician, you can end up with viewing the image that the pathologist used to make the diagnosis, an interactive pathology report. And that would be an opportunity to review the case with the patient. All right, gross images are important. And Sean Batty is a really terrific young pathologist in Australia, and he developed this 3D mapping technique where in about 2 minutes, using a turntable, a gross specimen is photographed and then mapped, and it's photorealistic. And here is, after 2 minutes, here's the image of the gross specimen. You can imagine showing that at tumor board. It's pretty remarkable. And you can incorporate the same thing into a path report. Here's a pancreatic pseudocyst, which has the same small little PDF embedded image that can be manipulated just by moving your finger. Quite remarkable. That's the paper, the future of paper. So trends that are going to evolve, more patient-friendly reports driven by consumerism. Patients want these things. There's going to be need for value-added connections, and the images and curated URLs and GPS-like features and augmented reality could become part of our path reports. And it'll become a practice differentiator. Those that do this will stand out from the crowd. Books will become more interactive.
Emma. Huh? Emma. 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 Emma.
So you can't go totally electronic, right? All right. We'll keep going here. That's it for paper. So the next trend, the rise of Smarties. All right, Smarties, if you live in the UK, are something that looks a bit like M&Ms. But to me, I'm using it to talk about smart things. All right, the evolution of technology, the home of the future.
Most of his time in the home of the 21st century. This equipment here will allow him to carry on normal business activities without ever going to an office away from home. This console provides a summary of news relayed by satellite from all over the world.
1967.
Now, to get a newspaper copy for permanent reference, I just turn this button. and out it comes. When I've finished catching up on the news, I might check the latest weather. This same screen can give me the latest report on the stocks I might own. A telephone is this instrument here, a mock-up of a possible future telephone. This would be the mouthpiece. Now, if I want to see the people I'm talking with, I just turn the button and there they are. Over here, as I work on this screen, I can keep in touch with other rooms of the house through a closed-circuit television system. With equipment like this in the home of the future, we may not have to go to work. The work would come to us. In the 21st century, it may be that no home will be complete without a computerized communications console.
A computerized communications console. We got one. Everyone has one in their pocket, right? And if you went to St. Peter's Square in 2005 for the death of Pope Paul II, there was one clamshell device in the crowd. And if you went to the same square for Pope Francis's election in 2013, everybody had a device. Remarkable over a few years. So this single device, this smartphone, has captured our lives to some extent. And there's now a disease called nomophobia, which is fear of being without your smartphone. And apps have just sprung up, and they've been they're remarkable, and a number of them are dealing with medicine. There's diabetes monitoring on your cell phone, and cardiologists can plug in their what's called a cardio sleeve, an electronic stethoscope, get an EKG. Ophthalmologists can use the device. Smart pills and watches that detect epileptic fits. There's lab on a chip. You can do DNA analysis and measurements on these devices, and it's like having a laboratory in your palm with electronic sensing and diagnostic measurements of infectious disease testing, and you can see the list here. So it basically is democratizing high-end measurement of testing, and a lot of big data is going to come out of this, and not all doctors are happy with that idea of patient-generated data, and it's a little unclear how pathologists are going to respond to that. We'll see. But to me, the future is in our genes, all right? And so my response is it's kind of smartphone pathology. You can use this device to photo and video our specimens, present cases, link to whole slide images, do video consultations. You can replace your microscope for $12. Not a great image. And I experiment with doing tumor board in my pocket, basically just walking into tumor board with everything on the cell phone, created on the cell phone. So there's devices that allow you to hook your cell phone up to the microscope and take images. This is a thyroid carcinoma, and they're very acceptable. We had a Naegleria case with CSF, and we took a little video of that amoeba moving around in the CSF, and theoretically you could use it FaceTime and talk to the surgeon directly in the operating room, all from that. All right, and you know, because of interest of time, I'll skip the demo, but if you ask me, I can show you a whole tumor board presentation case using your mobile device. All right, and the goal for me is at least to present everything not on the phone, but walking in with my Apple Watch or smartwatch or whatever, and present tumor board with that kind of device. Yeah, pretty slick. All right, so tools evolve, right? They change a bit, and microscopes are also in part of that evolution. And they haven't changed a lot over the years. They look a little bit different, but the whole goal hasn't changed much at all. There may be a bit more ergonomic now. And the future of microscopes, well, there's some very amazing designs out there that enable slide scanning and point of view imaging and inline holography and off-axis holographic microscopy, etc. All right, here's a scan that's not super high resolution, but it was done in about 30 seconds using a 2x lens. And for marking out areas of tumor, the histology is not that bad. All right, you've got handheld devices to help docs' offices and operating rooms, point-of-care microscopy, but you need to look beyond the glass, to life without glass. And this section is a tribute to Dr. Levinson, who has pioneered a slide-free histology, a MUSE system as he calls it, UV surface excitation microscopy. Now this is off of the paraffin block. There's no stain involved. This is just right off the paraffin block. So this is colon, and you can see a 3D representation. Here's colon cancer. I think totally diagnosable. No glass slide, no H&E. It was mapped, it was color mapping from one image to another. Breast carcinoma, standard microscopy on the left, and Richard Levinson's MUSE technology on the right. And you can see chromatin detail with nothing more than a paraffin section without no glass slide at all, just a paraffin block, all right? Here's a routine H&E of a breast case in situ. Here is the native MUSE image, and then with some simple color correction, this is the next image. And you'll notice that there's an area that here that doesn't show up in the H&E, and that's a small focus of malignant cells in a vessel there. And you can see the depth and the shadowing that's there from the 3D image. So our microscopes as we currently use them are not very smart. We don't have smart microscopes. But I think in the future we'll have a fusion of microscopes and computers, so-called smart microscopes, much like folks are pushing self-driving cars, right? Mercedes-Benz says the car is a smartphone on wheels. That's where they're going. They've got some amazing demos of that at the last CES meeting. You can park the car with your smartwatch, and the technology of cars is going to become more and more expanded and improved, and half the drivers want smart cars, and many of the components associated with smart car technology that Google has pioneered with a collision avoidance is now available in cars now. All right? So they have a little clip there. What happens if a cop pulls you over and it's a driverless car? Who gets the ticket? And Google had the very first, after over 1 million miles, the very first accident, bus pulled in front of the car and wasn't able to evade it in time. So I thought, if we got self-driving cars, why can't we have self-driving microscopes? That would be cool. We, as pathologists, spend a lot of time as hunters and gatherers, right? We count and we measure, you know, we look for things, and we count things, and we measure things. And wouldn't it be nice if the computer did all those things for us and helped us out, you know, made our lives a little bit easier. So I'm wondering about computing without having to mess with looking at glass slides directly. So we talk about reading slides, and I don't know how, when I read them, sometimes I can read, there's words there. I see B-cell lymphoma or CIN1, but other times when I try to read a slide, you know, I'm not the expert. So this is sort of what I see. I'm not sure what the heck that is, and so I've used many of you in the audience as consultants on those cases. But it'd be nice if the computer helped us, right? So we could look at the image in context and move from pixels, you know, to understanding what that diagnosis is. And there's software out there that's trying to do that. EyesFinder and Clarify trying to help recognition of the histologic image. So think about the future of apps. We've got our cell phones, smartphones, they've got applications on it, and you want software that works for you. So in the past, we were hooked on apps that notify us. It's like cocaine, you know, we're addicted to notifications, to little buzzes in our pocket that the phone has a message for us, and most of these apps are read-write, and they wait for you to do something, right? But I think in the future they'll be more proactive. Next generation of apps like Siri, Google, Slack, Nest, you know, they're going to ask, you're going to ask the software to do something, and it's going to go ahead and do it, and it's going to anticipate what you want to do, right? And it'll build an automated workflow. So here's an example, a personalized workflow. You're going to buy a ticket, and and then on an airline, and then the system scans your email and adds that flight to your calendar automatically. Google then notifies you that, hey, I know that the airport is 2 hours away and you need to drive, and so it sends a message to you saying it's time to leave home. It knows where you are, right? And then the next step is it tells you, well, this is the directions to get there and what you might avoid because there could be an accident. So those things are there. The technology of a personalized workflow is there. So how would that work for pathology? A computerized assisted workflow, right? How can we be more efficient? Well, Jeff Fine wrote a nice paper about regions of interest, nonlinear whole site evaluation, and he talked about optimizing the computer and the whole site image scan to produce a more elegant way of reviewing cases. So here's a sentinel node example, and currently we count the number of sentinel nodes or lymph nodes in a dissection. We search for tumor, it could be a rare focus, and we dictate a report. That's currently what we do now. In the future, with some computer help, we could evaluate the gross description. The computer would do that. It would display suspicious areas automatically for you by pre-screening the slide, and then automatically create a report. And we're not very far away from this. So we've got a case with some nodes there, and the computer could scan those nodes, find areas of interest, and as you know, the tumor, when it first metastasizes, is going to be out in the sinus there, and so it'll scan those areas first, and then lay out the most suspicious areas versus the least suspicious areas. So it can take you right to the area of interest and measure it, and you don't have to do the hunting. You just do the verifying. All right, so these computer-generated reports could automatically tell you how many nodes are involved, the size of the focus. It could analyze the appropriate supportive stains, cytokeratin, etc. And that's sort of the future. So looking at microscopes alone, you could have a tricked out microscope which has USB connections. You always need a few of those for charging things, and Ethernet and Wi-Fi connected microscope. There could be automation. It's going to be hassle to turn the turret, so that could be automatic push button. You could have autofocus, obviously, auto stage, a motion detector to move the turrets. It could have an embedded microscope that's voice activated, and we are used to having cameras on top of it, but it would be nice if we had a double camera, so it was facing us, so you could talk directly into the OR about what was happening and project the slide to the clinician. You could have a personal scanner next to your scope, do whole slide imaging, and there's companies that sell replacements for your stage that do the scanning for you. Many of our slides are already barcoded, and you could have a built-in barcode scanner on the bottom of your scope, all integrated into one device. Taking the next step, you could have laser dissection of the areas of interest for possible molecular and other studies. And all of it would result in live streaming and tablet sharing and integration of robotics into a collaborative environment where the information is sent to colleagues or clinicians as appropriate.
Cases to review. 18 of them are complex and will require extra time. Digital scans were done on 20 cases. 2 cases are colon carcinoma resections with lymph node dissection. I've reviewed the lymph nodes for you and analyzed them for metastases. Here is the workload breakdown of the new cases. Incidentally, there are 2 outstanding cases. The molecular studies are complete and you may be able to finish those as well. Shall we begin?
Wouldn't it be great? That's how our day started. Shall we begin? It's all laid out, ready to go, efficient, the computer there to help. Some of the technology has gone farther, where Oculus Rift testing is done on whole site images, so you're viewing the image on your on the goggles, right? I can predict a few, and there's a nice paper that Liron Pantanowicz did that you might, or a poster session actually, you might want to check out, where he talks about how that could be used in pathology for signing out cases. And here's your CLIA licensed remote office, where you could be reading out your cases as you're sipping on your soda. So other smart things that might come about. Now there's things called smart chopsticks, so that the tip of the chopstick, when it touches contaminated food, the LEDs at the end of it, chopstick, go red, tell you don't touch that food. There's something called anemia, which folks with gluten enteropathy problems, you know, it'll detect gluten and tell you whether or not that's a problem food or not. All right, stay away. There's a smart knife that can detect cancer cells and margins, and that's been written up in the Dark Daily. And so when that material comes to us to dissect out on the gross table, you can make better decisions about margins potentially. And I thought maybe that we could do a mock-up for the future, something called a smart cutting board. So we're used to cutting boards, and they now have special coatings on plastics that allow for self-cleaning. And I thought that's what we need. I don't know about your cutting board, but mine is always a mess, and it would be nice to have a self-cleaning cutting board that would repel blood and other stuff, and it allow weights and measurements. So this is sort of my mock-up of the future of something as simple and mundane as a cutting board. So we've got our USCAP branded cutting board. We've got a stain-resistant nano coating that doesn't resist everything from ink. We've got to blood. We've got our smart tools. We've got our built-in timer, so we don't want to miss lunch. We've got our specimen, and it will automatically sense the specimen, realize this is what the patient's name is off of a barcode on the specimen label. It'll then weigh it automatically and tell you how heavy that breast specimen is. All right, so we got 21.5, yeah, and then it'll automatically detect it. This is technology available today that it will do the measuring for you. So it makes your margins, it detects where the edges of the tumor is, it tells you the weight, the size of the specimen, and then it'll do an analysis, theoretically, that says, hey, there's the tumor. Now this is the area of interest, and where the nearest margin, it's a superior 0.3 centimeters. Makes our life in the gross table much more manageable. And here's an example of I don't know how distant future, where it could do lymph node analysis, a scan in the scan technology could tell you how many nodes are in your dissection, where they're located. You could then do carcinoma detection, because that signal would be different than a regular signal from lymph nodes, and it would show that there's 3 possible lymph nodes that might have carcinoma in it. That would make our lives a heck of a lot easier. So to me, the Internet of Pathology things is coming. We're going to have smartphones and tablets integrated into medicine. Other smart devices will arrive with labs on a chip and smart microphones, microscopes, and smart knives, and digital pathology will continue. The last piece here is selfies, all right? We've got all sorts of opportunities, foolhardy or not, to photograph ourselves with favorite beasts. Some of these, yeah, I don't know where that one came from. And radiologists can take their own selfies. And I had a chance to be on stage with Gene Herbeck at Cap 14 and got a selfie. There's now selfie brushes so that you can comb your hair and then see what it looks like. And selfies are not new to smartphones. There's 1920 and a bunch of guys are taking their selfie. And before there were phones and electronics, there was artists, right? And so we have hand-drawn selfies that were there. And there's now, selfie deaths have now matched skateboarding and is just behind bee and wasp stings as a cause of demise. And in some areas, like in India, police have signs that say no selfie zones, because people have walked into the water accidentally or fallen and caused damage. So I was thinking, what about the ultimate selfie, personalized medicine, where we've got a cancer and we're going to do a selfie of that cancer case, right? Understanding the host and that its uniqueness and the environment that it's in is unique. And I think in 460, Hippocrates said it's more important to know what sort of person has the disease than to know what sort of disease a person has. And those are very true words today, that each of us is unique and the tumors are unique as well, even though they look the same. And so heterogeneity now, I think in pathology has become we much more appreciate that these tumor cells have a variety of immunologic and genetic abnormalities. And you've seen this where in one area of the slide you got a 3+ HER2, another area there's no staining, and the tumor looks identical. So heterogeneity is something that we've, as pathologists, have becoming more and more accustomed to. Ki-67 stain, it looks the same, areas are strong and weak, and BRAF, etc. We're used to immunoscores, or it's a movement to increase this awareness of this scoring at the interface. And there are, for example, 2 patients here with liver mets, and these are 2 biopsies from the liver. Both have similar CEA values and LDH and no other lab abnormalities and KRAS and BRAF wild type. And both patients underwent chemo and with cetuximab, and one patient had a complete response and survived for 48 months, and the other had rapid progression and died in 4 months. And they look pretty much identical until you look at the edges, the seams. And that's where it shows you that the patient that did well had strong T-cell markers at the periphery. So we're learning that tumor morphology is very much driven by the environment that it finds itself in, and that's the survival statistics. And now we've got tools to allow us to measure that and treat that. That whole immunologic tumor environment is becoming, and you're the experts, there's many talks about this, that become more important for immunity, right? And so we've got a number of stains available, fish stains for varying subtypes of lymphocytes and T subsites and multiplexing. And now there's mass spectrometry rather, in which areas of tumor can light up. And Richard Levinson had a nice paper that talked about how to map mass spectrometry images to IHC stains, giving sort of a pseudo-IHC that's much more accurate. So we've got the immunoscore available and immunoprofiling, and that may be the killer app for digital pathology, as that we understand the importance of tumor microenvironment and how these drugs can impact the tumor. So we're living in the age of targeted therapy, and this cancer immunotherapy approach is ASCO's top advance of the year. So we're all recognizing that as pathologists, and it was the reason that Jimmy Carter had a breakthrough response to anti-PD-1 drug Keytruda. All right, so we will see, I think, in the near future, as we do, and actually now, epigenetics and the rise of phenomics and H&E morphology will be important, but it also needs, and often more importantly, to be taken in context. What is the microenvironment? What's the stroma interaction? What is the immune context? But there's a problem here, a fly in the ointment. So patients are lost, confused, and often our clinical colleagues are as well, about understanding all these different drugs and immunologic markers. And so I see a future role for pathologists. We used to be the Google, at least in private practice, maybe more so, that the clinicians would come to us and say, you know, would you look this information up? And our offices had the biggest library outside of the main one in the hospital as reference guides. And we were the Google of medicine before that technology developed. We were fact finder and librarian, and we had all the geeky pins. And now we have an opportunity for something new. We get to be guides and translators in the future, like the Rosetta Stone in 196 BC, where we were able to translate Egyptian, Greek, and hieroglyphics. So here is a snapshot from the Rosetta Stone, and it's not much different than what we see here, right? Mark Boguski has talked about that, and these actionable biomarkers, and we need to make this molecular data more understandable to clinicians. You get that, you understand that. That's why you're here taking courses. And we understand that, as Darwin described the survival of the fittest, tumor cells are also under a battle with our immune system. And as treatments are applied to those tumor cells, they evolve and they change, and different drugs have to be implemented, as you know, as the drug as the tumor turns from one type to another. Colon carcinoma evolves. If you look at the NCCN guidelines under soft tissue sarcoma, your future is in there. It's in the fine print, but on the bottom of this guideline for soft tissue sarcoma, it says consultation with a pathologist who has expertise in sarcoma diagnosis and molecular diagnostic techniques should be obtained prior to testing. So this document, it says we are gatekeepers. We are part of the medical team making decisions about how this patient is treated. All right, and if you look at a recent lab advance, you'll see that, I haven't seen that before, there's drug advertising on the insert for this pathology journal. All right? So we are becoming more recognizable, more recognized for our expertise, not just in histology, but also in how patients should be treated. We are now the integrators and interpreters of disease, and that's a job description we should embrace, the translators of disease. And there's a number of software tools like Crosstalk and others that show the disease and the biomarkers and the drugs that can be used to treat. So sort of a molecular tumor board approach. Very, very important. So I predict, and we already have it actually, that pathology finally gets personal. The future trends are, we'll see the importance of phenomics and epigenetics and something called 3D biology. We'll have immunoscores important as anything else in terms of TNM scoring. We'll have new tools that will enable patients to appropriately treat patients with our guidance, and we will recapture our Google heritage of providing important information and next steps for care. So let's wrap things up. So I see a digital future, all right? Faster, better, cheaper, right? The workflow is going to change. It'll be dramatically different, hopefully making us more efficient, not inefficient. We'll have computer-assisted analysis with pre-screening of slides. So which slides, prioritizing which we need to look at next. We'll have previous cases pulled up automatically so that we compare the current case with past cases. We'll have automatic IPOX ordering so that we don't over-order those precious stains. All right? Some of the tedious tasks of counting and measuring will be done for us automatically by computers. And that integration with the APLIS and the hospital's information system will become more important, and our textbooks will become more enhanced and educational and interactive. I see an opportunity for machine learning and pattern recognition, and we'll go beyond morphology into genomics and proteomics. And many of the courses have, during this USCAP conference, focusing on those. We'll have 3D scanning and data processing, and tissue become multidimensional and unique to each patient. Now some folks are gonna say, I can't see this happening. I can never see a diagnosis made by a computer. Well, that may well be, but how about a diagnosis made by a pigeon? All right, some of you have seen this article by Richard Levinson, and please buttonhole him and talk about it if you wish. So, our computer as smart as a bird brain. All right, so here's the setup. We've got the pigeon, and we've got a image there, and we've got a bunch of pictures that are benign versus malignant, and the pigeon, if it hits the right button after looking at the image, is rewarded with some corn, and if it misses it, it doesn't get the corn. All right, so here is a little video that describes that process if you haven't already seen it, and this video has over 60,000 views so far on YouTube. So the trial starts with the pigeon knowing it's got to at least peck this. And then once it pecks, it sees an image presented to it. It needs to observe it and do 3 additional pecks are required before anything happens. And then 2 buttons show up. It's 2 choices. You know, is this benign or is this malignant? So the pigeon touches one or the other, and if it's the right answer, it gets rewarded with some bird seed. All right? And this is repeated, and the pigeon gets better and better at making a diagnosis. All right? So they did a number of trials with benign images, and the yellow button is correct, and the pigeon nails it right there. Gets its reward, sees the next image of the breast lesion up. Another benign one, hits the yellow, gets its reward. A little trickier, this one here. It looks, it goes, nah, that's benign for sure. All right, yellow gets its reward. All right, so then they switched over and tried malignant diagnoses. You know, the pattern's different. It's the blue, right? Malignant, got it. And then it goes and gets its reward. And the same thing, we've got an infiltrating breast carcinoma here. It looks, yep, the pattern's different. And pigeons, turns out, have one of the most amazing pattern recognition neurosensory apparatus of all animals and other avian species. So at the end of the training, pigeons averaged 85 to 90% correct responses. Pretty amazing. And you can see here at the beginning, you know, they got half of it right. You know, at the beginning, they're 50% right. It's just a guess, but within a 2-week period, they were hitting 85 to 90% accurate. And then they rotated images, thinking that the pigeon might have memorized something. And you can see these pigeons nail it every time. They want that seed. All right? So, but we know this isn't true. This is not real life in pathology, because there's one button missing, which is one we use a lot. So that button, the pigeon needs to be told that there's some things in the middle. And they had no opportunity to equivocate. So here's our future PAs here, all lined up with their certificates of completion. But some of you are sitting there going, I don't like this. You know, I want that old-time pathology. I don't want this pigeon stuff. And as pathologists, we do cling to the old, right? All this new whole-side image stuff and in vivo microscopy, what the heck is that? Well, you can go back to Socrates, who was worried that writing would weaken human memory and stifle judgment. So he was against writing. So think about that. Things evolve, the tools evolve. And it's not, you know, you can think about the rise of the machines and the singularity and 2001, How Can I Help You, Dave? Man versus machine. But I think what's going to happen in our lives is we're going to have an integration of machine and man. A hybrid approach will be much more receptive. And I'll give you the example of chess. Some of you already know this that are really into chess. But Kasparov, in 1997, the world champion of chess, was matched up against an IBM computer called Deep Blue. And for the very first time in history, the computer beat the world champion. All right? And what did Kasparov do? He didn't go and sulk. He came up with a new way to do chess tournaments called freestyle chess. And he divided groups of people into those that have unassisted humans, grandmastered, whatever, no computer assistance at all. The second group of people had a computer alone, and the human only moved the piece, directed by the computer. And the third was a hybrid, what was called a centaur, which was the computer and the human collaborating. All right, so you look at 2014, who won? Well, the pure AI computer alone, won 42 games. The hybrid, humans and computers, won 53 games. And these humans were amateurs. These were not grandmasters. So the interaction of humans and the computer algorithms were the best players in the world. And currently, the best player alive is called Integran, and it's a bunch of humans with several chess programs. All right? So what's the message here? Well, for me, it tells you that computers can help us be better at what we do. We can be better chess players, pilots, teachers, judges, doctors, and pathologists with the assistance of computers and computer programming. You know, it's not so much artificial intelligence, but more artificial smartness, using the tools to our advantage. So we've got Rudolph there, and we've got Watson, and I don't think they're going to compete. I think there's going to be a collaboration between man and machine, and pathologists are there in the forefront, because we're used to IT. We help run the IT department. We're very integrated into that part of the of the pathology world. So I see computer-assisted diagnoses that will produce better diagnoses and better reports than just humans alone, much like the chest example. What about an app? We all need an app to do these kind of things. And so I was thinking, if I were designing a computer program that would help me with diagnoses, I'd want to have a slick app that was my sidekick, my associate, my help. So I looked on the internet, and this is sort of a list of sidekicks: Igor and Spock and Bubba, along with Gort, some of you, and Cato and the green. What was it? Green. Yeah. And Robin and Batman and Watson and Sherlock Holmes. So I thought, what would a nice name for a pathology assistant be? A good app for us. So I settled on this one. I like Samwise. I mean, this guy was straight arrow, and he was there to help. So I thought, I want to design an app that is Samwise. That's the name I would give to it. And what would it do? So I made up this little video about what it would do. It would be your digital partner, right? It would do an historic scan of previous cases and pull up the gross and the mammogram and whatever x-rays. It would scan the slides, the whole slide images that were there. It would then do an analysis of those whole slide images and put them in a particular order that you should review with important areas to look at and diagnose. It would do all the counting and measuring for you that we are not happy to do. It could auto-order some immunostains. It would pull up the resources that you could use to make the right diagnosis, all in one app. So I call that app Samwise, and I'm hoping at a future USCAP, one of the vendors is going to have that app available for us to purchase. So my near future view is that pathology's future will be based on our ability to predict, not diagnose. The better that we predict, the better the prognosis. And we need to become more patient-focused, anticipating our patients' needs by moving from diagnosis to help planning therapy. And with the help of Tom Grogan, this is what I think is the pathology report of the future. Here's a B-cell lymphoma. It's got integration with the EMR. It has all the stains appropriately evaluated and shown. It's got whole slide image scanning of appropriate slides for review. It adds in the molecular testing, and it is able to push the information out to your mobile device as appropriate for clinicians to review the case. It then integrates the smarts of Watson and other computer-assisted programs to make you much, much better than you currently are. And it'll finally, what the patient wants, what's the appropriate treatment. So this is the ultimate pathology report, and I think that's the future of where we're going now. We no longer should be looking at, and that's the one report to rule them all, right? The E-report to rule them all. So the future is here. We can ignore it, or we can embrace it. Some of the things I've shown you are a bit out there, but most of the things are very close to what's available now, if not currently in our arsenal. And we shouldn't be Timexes, right? Things have changed, right? There's now opportunities to integrate technology into our pathology space, and we need to embrace that change and prepare for the future. It's already here. It just isn't very well distributed, as William Gibson said. So that's my message. I'm going to stick to it. And I'll finish with this. The secret to creativity is knowing how to hide your sources, according to Einstein. Well, I'm not going to hide any of my sources. In the interest of how the USCAP, under David Kaminsky's leadership, has embraced technology and graphic design and all that, I thought I'd come up with you know, this was some emails that were sent out. The course is with them. So these are the folks that I call USCAP stars that helped, you know, ideas I stole from them and integrated and stuff. So I'm being upfront of all the different people that I have worked with, Richard in particular and others. It's just a remarkable group of folks that have helped put this together, and particularly I want to thank the USCAP team and David in particular, and John for inviting me here, a sort of a lowly community hospital pathologist who just loves moving stuff around on the screen. So thanks for your attention. Thank you.